Okay, guys, we're up, so I'm going to hop off. Have a
Okay.
great event.
Okay, thank you. Good morning and welcome to COVID-19 vaccination webinar being brought to you by Kingdom Worship Center along with Radio One and with collaboration from Johns Hopkins Bloomberg School of Public Health. So those of you who are not familiar with KFCM, we're a synergistic organization of fellowships, alliances, churches, parachurch groups, and businesses relating to each other through common vision and mission and the pursuit of the kingdom of God. KFCM, if you're out there, yell at us this morning, let us know you're there. I'm your host, Archbishop Ralph Dennis, the presiding bishop of KFCM. Today, I want to talk to you, we want to talk to you collectively about the COVID-19 pandemic and the many challenges that has presented to us for the last year, both here in Maryland, here in the United States and abroad. As of yesterday across the US, there has been 29,700,000 cases of this coronavirus, with 540,000 deaths. 61,000 new cases were added on yesterday as we're dealing with people dying all over the place, some in your family and some in mine. Ladies and gentlemen, I think you see that we're dealing with something very serious here and we can't take it lightly. Today, our objective is to talk to you about this COVID vaccine that's out from the context of race and ethnic health perspectives. We will talk about the virus, the variants, the vaccine, the vaccinations, and how all these affect people of color. We will tell you why we believe that taking the vaccination is the right choice to make. We also want to talk to you about underlying health and social inequities that put many racial and ethnic minority groups at increased risk of getting the virus, becoming sick, and perhaps even dying. Because of what we have learned from COVID-19 pandemic, we must discuss also what we can do to move toward health equity, which means that everyone has the same opportunity to be as healthy as possible. Here to moderate us today in our discussion is Pastor Frida Anderson, who with her husband, Bishop Joel Anderson, pastor the Open Door Fellowship here in Baltimore County. Please receive her at this time as she moderates and takes us through this very needed discussion. Good morning, Frida.
Good morning, Bishop. Thank you so much for that warm welcome. Good morning to all of our panelists and especially to those who are in our listening audience and to our keynote speaker today, Dr. Kausar Talat. Again, my name is Frida Anderson, and I serve as the Senior Regulatory Compliance Specialist for the Center for Immunization Research at Johns Hopkins Bloomberg School of Public Health. Today, I have the pleasure of introducing my colleague, Dr. Kausar Talat. She is the Assistant Professor at the Johns Hopkins Bloomberg School of Public Health, and she serves as Principal Investigator at the Center for Immunization Research. She is an expert in infectious diseases and has conducted numerous vaccine clinical trials in healthy adults, including outpatient studies and inpatient challenge studies. She's focused on diseases such as the avian flu, pandemic influenza, as well as enteric diseases. Most recently, Dr. Talat has successfully completed the Pfizer COVID-19 clinical trial at Johns Hopkins. Will you help me welcome her today as she shares in her area of expertise to enlighten us on COVID-19, coronavirus, and vaccines? Welcome, Dr. Talat.
Thank you so very much, Frida. It's a pleasure to be here and talk to KFCM. And also, thank you very much, Archbishop Dennis, for your invitation. It is my honor to be here. Thank you. So I'm going to start sharing my slides, if that's okay. Can everybody see those okay? Okay, great. So as Frida mentioned, I'm going to talk about the COVID-19 vaccines today, and I want to start with a little bit of background about the disease. We've all heard about it. It's been over a year now that this has affected our lives and our communities, but just bring a little bit of attention to the factors that spread the virus in our communities and what increases our risk. So crowded situations, close physical contact, enclosed space, and how much time you have in contact with somebody who's infected. The other thing that is important to know is who is at risk for having severe disease from COVID infection. And we've learned over the last year that there are certain diseases that put people at increased risk. So older patients, males, hypertension or heart disease, diabetes, obesity is a risk factor all by itself, regardless of what other illnesses somebody may have. Chronic lung disease, cancer, chronic kidney disease, and also pregnancy can put people at increased risk. And we know that age, especially as we get older, we're at increased risk for both hospitalization and dying. And so this is a chart from the CDC that shows that compared to children between the ages of 5 to 17, adults are more likely to get infected. Young adults especially are more likely to get infected. They are much more likely to get hospitalized. And as you march across, the older you are, the more likely you are to be hospitalized if you are infected. And so if you're over the age of 65, you're 35 times more likely to be hospitalized compared to a 15-year-old. And they're also more likely to die. And so as we get older, if you're 50, you're between the ages of 50 and 64, you're 400 times more likely to die compared to a 15-year-old. And so this brings to mind why it's really important for people to get vaccinated and why especially our elders should be vaccinated, because they're the ones that are most at risk for severe disease and dying. We also know that people of color are disproportionately affected by this disease. And I know that there will be a discussion about this after my talk on the vaccines are done, but I want to talk to show this slide a little bit. This is from the CDC. And if you look at Black African American people in the United States, they're more likely to get infected with COVID compared to white non-Hispanic people. They're almost 4 times more likely to be hospitalized and almost 3 times more likely to die. And this is also true for people of Latinx descent. So they're 4 times more likely to be hospitalized and almost 3 times more likely to die from COVID. And so our communities also need to be protected, everybody in our communities, just because people who are African American or Hispanic also need have a much higher risk rate of severe disease and death. So how do we slow the spread of COVID? I mean, these are things that we've heard about over the last year. It's important to wear a mask. It's important to stay at least 6 feet apart from people who don't share your household. Especially if you are not wearing a mask, it's important to wash your hands and to clean and disinfect. But now we have a wonderful new tool at our disposal, and almost 20% of the United States has already been vaccinated against COVID-19 with one of the new vaccines. And so I'm going to switch now and talk about the vaccines. And hopefully there'll be an opportunity to ask questions after I'm done speaking. So vaccines work by teaching the body to recognize and fight invaders. So when we give the vaccine, the body starts sounds an alarm against the COVID proteins. The fighter cells and antibodies go into action, and so they produce antibodies and other immune cells. And so the goal is to block the virus should we ever be infected with it. And so our vaccines induce the immune system and prevent us from getting sick when we see the virus. So the goal of the vaccine is to develop an immune response to a virus or a bacteria or a parasite. But today we're talking about a specific virus, COVID-19, the one that causes COVID-19, the SARS-CoV-2 virus, to develop memory for that immune response, because and you can have a short short-lived immune response that protects you for a short period of time, or you could have a long-lived immune response that protects you for a very long period of time. And so the goal is to develop a long-lived immune response. And the most important goal of a vaccine is to protect against disease when you're exposed to that virus. So we know that at some point in our lives, we will come across viruses, and it's very possible that we'll come across the virus that causes COVID-19. But if we're vaccinated, the goal is not to get sick from it. And we also want to protect against infection with that virus. But the most important goal is to protect against disease when we get exposed to that virus. And it's not just protecting the individual, but we also want to protect our communities. So this is a graph of what's called herd immunity. And herd immunity is a really important concept in infectious diseases and in vaccines. So we're going to start with the panels on the left. If you have a population in blue here, where most people have no immunity to a virus, to COVID-19, and one person enters that population who has COVID-19, the person in red, then that person will spread the disease to the people that he or she contacts. They will get sick with COVID, and then they in turn will spread that disease to the people that they come in contact with. And so by the end, everybody in the community will get sick or be exposed. Some people will eventually die. And we can get to herd immunity through natural disease, but as we've seen, as Bishop Dennis said, with not quite 30 million people infected, so not even 10% of our population, we've lost over 500,000 people in our country and from our communities. And so to get to a point where you can have herd immunity through natural infection would mean many, many more people would have to die. So the wonderful thing about vaccines is it could provide immunity. So people in orange are people who are vaccinated, and so they provide protection or immunity. And so when somebody enters the community who has disease, they can maybe spread it to one person or two people who are not vaccinated, but because everybody else around them is vaccinated, they stop the transmission of the virus. And not only that, but they can protect those people in blue here who are either unable to get the vaccine or who are immunosuppressed or immunocompromised, and so the vaccine may not be as effective in them. And so vaccines are a really good way to provide herd immunity, a safe way to provide herd immunity. We have used this to stop the transmission of polio in the United States. We've used this to eradicate smallpox from the world and to stop outbreaks of diseases such as measles. But you need to get to a certain level of the population that is protected so that the disease doesn't transmit in that population. And for COVID, we think that that's somewhere around 70 to 85% of the population needs to be protected against in order to achieve herd immunity. So I've heard a lot about how could we have vaccines so quickly? It's only been a year. How do we have vaccines? How do we know that they're safe? And this is a graph that just shows the steps of going through clinical trials in order to get a vaccine or any medication licensed in the United States. We do studies. We start before we do any studies. You have to apply to the FDA to get an investigational new drug application. The FDA will review all of the data and all the pre-human studies to make sure that the vaccine looks like it's going to be safe and effective. And then when you go into people for the first time, you start slow. You start with a few dozen people just to look at safety. And if that looks good, then you start with a few hundred people to look at safety and the immune response and define the dose. And then you move on to thousands and thousands of people to look to see if the vaccine is effective. Even after a vaccine is licensed, we also continue to observe hundreds of thousands and millions of people who receive the vaccine to make sure that the safety and the efficacy continue to be what we think they're going to be after the trial. Now, usually this process takes a long time, many years, and it takes a long time because we're generally very cautious and we're more we're particularly cautious with money, because as you go up in the phases, the trials become more and more expensive. And so nobody wants to spend the money to do those trials until the first phase is completely done and we know that the vaccine is going to be effective. But for the pandemic, what we did was we invested a tremendous amount of money to speed up this process. We didn't skip any of the phases, but we overlapped them, and we got ready for the next study as soon as the first study was even started, just so that we could speed them up as quickly as possible. The same number of people have been vaccinated, the same safety precautions have been taken, but we did it at a much faster timeline, sacrificing money in order to save lives. So I'm going to switch and talk about the individual vaccines now. The first two vaccines that I'm going to talk about are the two that were first authorized in the United States, the mRNA vaccines. And this is a really nice infographic from the Philadelphia Inquirer that talks about how these vaccines work. And so the mRNA vaccines have a little piece of the RNA of the spike protein, or the red parts here on the coronavirus, the spikes, that are the most important part of the virus for invading cells and for our developing immune responses to them. And so when we take a little piece of that RNA from the spike protein, we put it in lipid nanoparticles or lipid spheres, basically tiny lipid bubbles or tiny fat bubbles. And the fat is really important because it helps stabilize the RNA and also helps the RNA enter the cells. So when we inject the RNA in these little fat bubbles, the fat helps the RNA enter the cells, and the RNA goes into the cytoplasm of the cell, which is where the cells know what to do with RNA. And so our cells make thousands and thousands of messenger RNAs every day that tell the cells what proteins to make, what enzymes and hormones. And so our cells know what to do with this RNA. The RNA enters the cytoplasm, or the outside part of the cell. So think about the cell as being like an egg with the cytoplasm as the white part, and then the nucleus is the yolk. The RNA stays in the white part of the cell. The ribosomes, which are protein-making factories in our cells, take the RNA and make proteins. The proteins travel through the antigen-presenting cells, or with the cells that help launch the immune response, to lymph nodes, where they meet with all the different immune cells that we have, the B cells and the T cells, and make antibodies, memory, and T cell responses. And so if our body then, after we've been vaccinated, sees the coronavirus or the virus that causes COVID, then we know how to respond to it, and we can kill and neutralize the virus before it ever causes disease. So the first mRNA vaccine that was authorized in the United States was one made by Pfizer and BioNTech. This is a modified mRNA vaccine. So it's just like the slide that I showed before, in a lipid nanoparticle. It codes for the spike protein. This vaccine is given 2 doses 3 weeks apart, and is stored at -70 degrees Celsius. In the trials that were done, where they were done primarily in the United States, but also had people enrolled in Argentina and Brazil. This is the demographics. So 10% was African American, which was a little bit lower than the 13% African American in the US population, but better than many clinical trials. 26% were Hispanic and Latino, and 21% were 65 and older. The vaccine is incredibly effective, and I'll show you on a subsequent slide. So it was 95% effective at preventing any illness from COVID, starting 7 days after the second dose. And what's really fantastic, because we don't usually see that with vaccines, it's 94% effective in people over the age of 65. And so the FDA gave this vaccine emergency use authorization on December 11th for people 16 years and older. The other vaccine is the Moderna NIH vaccine. It also is an mRNA vaccine in a lipid nanoparticle. This one is given 2 doses 4 weeks apart. And it's a little more stable at normal temperatures. So stable for 6 months at -20, which is a normal freezer temperature, or 30 days at refrigerator temperature. The phase 1 trial enrolled 30,000, phase 3 trial, enrolled 30,000 volunteers in the United States. And 25 were over the age of 65, 20% were Latinx, and 10% were African American. And this vaccine was found to be 94% effective starting 2 weeks after the second dose. And they received their emergency use authorization on December 18th for those over 18 years and older. Now, these vaccines are reactogenic, as we like to say, and basically they do have side effects. And now those side effects are totally normal. Pain at the injection site is the most common side effect in most people. There's also redness and swelling at the injection site. You can have fatigue, headaches, muscle aches, and chills are the most common systemic effects. Most of the side effects, especially the systemic side effects, are worse after the second dose. And there can even be some fever, especially in those who are younger. And younger adults have more symptoms than older adults. And these symptoms basically mean that your immune system is responding to the vaccine, and they're worse after the second dose because you've already seen the vaccine once. And so your immune system is responding even more robustly. As we get older, our immune system starts to be a little bit weaker and a little less reactive. And so we're less likely to have those side effects because our immune system is a little less robust. This is a graph that shows just how effective these vaccines are. So this is the Pfizer vaccine. In this chart is days after the first dose given on day 1 here, and then the percent of people in the study who develop COVID. And every circle or every square is somebody who gets sick with COVID-19. The blue line is the people who got placebo. The red line are the people who got vaccine. So in these trials, half the participants will get a saltwater injection or placebo, half will get a vaccine. They go on to go do their normal activities and their normal life. And then they call us if they get sick because they happen to have been exposed to COVID. And as you can see, really early, starting about 2 weeks after the dose, and it's the blow up here, you can see it's really 12 days after the first dose, these curves separate. And the vaccine is incredibly protective, whereas the people who received the saltwater injection or the placebo continue to get cases of COVID. And after these vaccines were authorized under the emergency use authorization, the people who got placebo were offered the vaccine as well. And this is the same graph for the Moderna vaccine. So it's equally protective about 2 weeks after the second dose, where it's from that point, it's 90% effective. And then, so 2 weeks after the first dose, it's about 90% effective. And then 2 weeks after the second dose, it's 94% effective. And the other thing is that there have been real world data from Israel, which has vaccinated about half its population already, that shows that the vaccines are incredibly effective, even in the real world, even against some of the variants that we'll talk about. What's really nice is that the vaccines work in all groups that they're tested in. So in all patients, this is just for the Moderna vaccine because they broke it up really nicely. In all patients, it's about 94% effective. In people over the age of 65, it's about 86% effective, but the range is the same. In people who are at risk for severe COVID because of underlying illness, it's still the same efficacy. In males and females, it's the same efficacy. And in people of color, it's the same efficacy as in Caucasians. And so it's really reassuring that it enrolled a wide variety. These studies enrolled a wide variety of people, and the vaccine seems to have the same efficacy in all of these populations. The next vaccine that has received the emergency use authorization is the Janssen or Johnson & Johnson vaccine. This one's made a little bit differently. Instead of using a lipid ball full of mRNA to give the vaccine, they use a cold virus that has been undergone deletion, so it can't replicate. It's no longer alive. It's not. It can't cause any disease, but it just serves as a vehicle to bring the genetic material from the COVID virus, the spike protein, the genetic material for the spike protein from this COVID virus into our cells so that our cells can then take that genetic material and make the spike protein so that our immune system can respond to it. So it's a very similar mechanism. It just uses a different platform to do it. They did a 1-dose trial, and this is a dose that was given. They enrolled 45,000 volunteers. This is the most international trial. It enrolled people in the United States, but also South Africa and Brazil, as well as many countries in Central and South America. And now they're doing a 2-dose study. The vaccine is stable for 2 years at regular freezer temperatures and 3 months in the refrigerator. There are side effects, and I'll show you in the next slide. So this is the side effects after the vaccine. About 60% of people have any side effect. The blue is people under the age of 60. The gray are people over the age of 60, with the light colors being the people who receive placebo or salt water, and the darker colors, people who receive the vaccine. So again, 60% of the people, of young adults, had any side effects. Almost all of them had pain at the injection site after that first dose, and 35% of older adults had side effects, again, because their immune system is less robust, and so they're less likely to have those side effects. There are also headaches, muscle aches that can happen after the first dose as well. There's a lower incidence of fever in this study, just slightly. It's 13% compared to the mRNA vaccines, but the side effects are very comparable. The vaccine is remarkably effective for a single dose because it was done at a different time in different populations and using different definitions of disease than the mRNA vaccines. It's very hard to compare them, but the efficacy against any COVID disease in the United States was 72%. Overall, it was 66%. But in South Africa, the efficacy was lower because of the variant in South Africa that makes the vaccines a little less effective. What's really important is it's 85% effective against preventing severe disease, and it was 100% effective against any hospitalizations and deaths starting 4 weeks after the vaccine was given. So 1 dose by 4 weeks after the vaccine is given can prevent all hospitalizations and deaths, which is a really big deal. And this vaccine received emergency use authorization in the United States in February 27th, so just a couple of weeks ago. There are 2 more vaccines that are in late clinical trials, and so we should be hearing about them getting emergency use authorization sometime in the near future. The AstraZeneca vaccine uses the same technology as the Johnson & Johnson vaccine. They just use a different adenovirus. This one's a chimpanzee adenovirus, but it also expresses the spike protein. The vaccine is stable at 2 to 8 degrees Celsius. The side effects that are experienced by most people are more common after the first dose. This vaccine is given 2 doses 4 weeks apart. There's pain and tenderness at the injection site. Fatigue, headache, and muscle aches are fairly common. And again, it's worse in people who are younger than older. This vaccine has now been given to over 47 million people around the world, and is very safe and well tolerated. The last vaccine is a Novavax vaccine. This one's a little bit different. It's more of a traditional vaccine. It's called a nanoparticle vaccine, and it has the spike proteins already made for our bodies. So our bodies don't have to make the spike protein, but in order to boost the immune system, because just protein alone wouldn't give us a very strong immune response, they put something else called matrix M, which is basically lipids, to give the immune system a little boost. This vaccine is given 2 doses, 21 days apart. There's mild side effects with pain and tenderness at the injection site. Like the mRNA vaccines, it's worse after the second dose. Headache, fatigue, and muscle aches happen, and there's very good immune responses in the phase 1 and 2 studies, and the phase 3 study is ongoing. So hopefully we'll hear about that soon. We've heard a lot about variants. So there's 3 variants that we've been paying very close attention to. The UK variant, or the United Kingdom variant, is B.1.1.7 that arrived in the United States in September of 2020. The South African variant, the B.1.351, arrived in October, and the Brazilian variant P1, which arrived in January 20. All of them have this and one mutation that makes it spread more easily and from person to person. And so, for example, the UK variant is spreading very quickly through the United States and will probably become the most common variant by the end of March or the beginning of April. The South African and the Brazilian variants have a second mutation that make it a little bit more resistant to the vaccines, but the vaccines should still work, especially to prevent severe disease. So the vaccines seem to work really, really well against the UK variant, so we don't have to worry so much about that, but there may be a decreased efficacy against mild, moderate disease with the South African and the Brazilian variant. So we know that these viruses are constantly changing through mutations, and the mutations appear over time. They also spread more easily, but we don't know completely how widely they've spread and how we don't know exactly how the disease caused by the new variants differs from the current circulating disease. We do know that in the United Kingdom, it appears that the UK variant causes more deaths and more hospitalizations than the previous strain. And I think the one thing we do know is the best way to stop these variants from spreading is to get vaccinated and be protected, because the variants show up in people who are infected. And so if we are not being infected, then the variants can't appear. So who should get the vaccine? Everybody who's eligible, and we'll talk a little bit about that in a minute. There is still limited supplies of these vaccines, but this should increase over time. And the president thinks that we'll have vaccine available to any adult who wants it by May, which is fantastic. The vaccine should be free to everybody. The government has bought all of the vaccine, and so nobody should get charged for it. However, insurance companies may be charged an administration fee by the providers, but no individual should have to pay that administration fee. The government has a fund, so if you are uninsured, then the government will pay for that. In Maryland, we're currently in phase 1C, which are adults age 65 to 74, and essential workers in lab services, agriculture, manufacturing, postal services. Anybody in phase 1B and phase 1A is still eligible to get the vaccine. And Maryland will be going to phase 2, which are adults 16 to 64, who are at increased risk of severe COVID illness due to comorbidities on March 30th, I believe. And then hopefully by May 1st, everybody will be eligible to get the vaccine. So how about those who've had previous COVID disease or illness? While we think that having had COVID in the past will protect you from getting reinfected, we don't know how long that will last, probably at least 6 months, maybe longer. But the immune response that is given to the vaccine is better than the immune response to getting infected on your own. And so you should still get vaccinated, but nobody should be vaccinated while they're sick or when they're in the isolation or quarantine period. So if you know that you've been exposed to somebody with COVID, getting the vaccine won't prevent you from getting sick, because the immune response takes too long to start and the illness will start before that immune response. So you should stay home and isolate or quarantine, and the CDC recommends waiting 90 days after you've been sick in order to get the vaccine. And what we're learning more and more is in people who have been sick before, that illness gives you sort of the first dose of the vaccine. Your immune system's already seen the virus. And so one dose of a vaccine is likely enough to give you good, long-lasting protection. And what we see is that the immune responses are better after one dose, or as good as people who have not had COVID, who've gotten 2 doses of vaccine. Also, the side effects are worse after the first dose, which again goes to show that the immune system has seen that spike protein before and is responding to it. And so you have more side effects after that first dose. If you got monoclonal antibodies or convalescent plasma, you should wait for 90 days after you receive it to get vaccinated. And the reason for this is so it doesn't interfere with the immune response to the vaccine. People who are immunosuppressed were not included in the clinical trials that I've mentioned, but millions of them have been vaccinated. As we are, the United States has now fully vaccinated almost 15% of the population, and more than 20% have received at least one dose. The vaccines are expected to be safe in people who are immunosuppressed because none of these vaccines that I've talked about are live vaccines, and none of them replicate inside of us. But it is possible and potentially likely that the vaccine efficacy, how well the vaccine will protect somebody who's immunosuppressed, may be decreased if the immune response is not as good. But any protection is better than none, and hopefully it will prevent severe disease, even if it doesn't prevent infection. And so it is important that people who are immunosuppressed get the vaccine, but it's also important that the people they come into contact with regularly can get the vaccine so they could form a protective bubble around them. And hopefully prevent the virus from ever reaching them. For pregnant and breastfeeding women, the studies did not include pregnant women, and there's no known increased risk to pregnant or breastfeeding women from these vaccines. Again, these are not live vaccines. They don't cross into breast milk and they don't cross the placenta. The risk of COVID disease is higher in pregnant women, especially, and they're more likely to be hospitalized and to have bad outcomes from their pregnancy. And so the CDC recommends that pregnant people who are in a group that is recommended to receive the vaccine have the choice to be vaccinated, and they should talk about this vaccine with their healthcare providers. For children, the Pfizer vaccine is licensed for children age 16 and above, assuming they're in a priority group. The Moderna vaccines and the Johnson & Johnson vaccine are only in those who are 18 and older. There is no vaccines that are currently available for those under 16, although I anticipate that there are, because there are trials that are going on right now for children over 12 years and older, I anticipate that sometime later this spring or early summer, the vaccines will be authorized in those who are 12 and older. And so it leaves just those who are 12 and younger who don't have access to the vaccines. The trials are starting in those who are under the age of 12. Moderna just vaccinated the first kids under 12 this week, and Pfizer will be starting in about 10 days or 2 weeks, 10 days. And then the Janssen study is going to be starting their adolescent trial any moment. And then we'll move on to younger children if it's shown to be safe and immunogenic in the adolescents. So hopefully by late fall, the vaccine will be available to everybody. There are people who should not receive the vaccines, and these are the only real contraindication to vaccines at this point is allergies. And so this is for the Pfizer and the Moderna vaccines on the left. If you have an allergic reaction to one of the vaccines, you should not receive the other because they're so similar in the way that they're made. People who have an allergic reaction to the first dose of an mRNA vaccine or know that they have an allergic reaction to something called polyethylene glycol, which is in those vaccines, have a precaution against the Johnson & Johnson vaccine, but they could potentially get the Johnson & Johnson vaccine to protect them. And the CDC recommends that they get it 28 days after their first dose. For the Johnson & Johnson vaccine, we haven't seen allergic reactions to that vaccine yet, but it's very new. But people who have a known allergy to polysorbate, which is a component of that vaccine, shouldn't take it. And they also can't take the mRNA vaccines as well because there's cross-reactivity. So that's really the only people who can't get the vaccine right now. The only adults who can't get the vaccine right now are those who have allergies to one of the vaccine components. The safety of vaccines is a top priority for everybody involved in vaccine development and rollout. And so there's a wonderful infographic on the CDC website called The Journey of Your Child's Vaccine. But the bottom part, the green part here, talks about how vaccine safety is monitored after a vaccine is authorized or licensed for the public. And there's multiple systems, from the vaccine adverse event reporting system that anybody can report to, vaccine safety data link that monitors large health healthcare organization network records. So it's anonymous, but they're monitoring for signals all the time to see if there's any safety signals. And the Clinical Immunization Safety Assessment Project that serves as a consultant to providers who have questions about vaccine safety. So all of these have been ramped up and are working incredibly hard since these vaccines have been authorized to make sure that the vaccines remain safe as they're rolled out into millions and millions of people. The CDC did introduce a new app called vSafe, and it's a new smartphone-based monitoring system for people who receive the COVID vaccine. And so when you get the vaccine, you'll get information about vSafe, and you should absolutely register and enroll in vSafe. And it records adverse events after vaccination. And they gather data from this. And so in the 1.6 million people who enrolled in vSafe, they were able to figure out what kinds of side effects they had after the vaccine. And it was very, very similar to what we saw in the trials. So from the first dose, people had pain at the injection site. There was some fatigue, some headaches, some muscle aches, a little bit of fever. They didn't have enough data on the second dose of Moderna because of the timing of this paper compared to when the Moderna vaccine was authorized, but they did have data from the second dose of the Pfizer vaccine, and you saw the same side effects, just a little bit more after the second dose than you did after the first dose. There are some unknowns about the vaccines. We don't know how long protection will last. We don't know if boosters will be needed, especially with the variants. We don't know whether these vaccines will prevent asymptomatic infection or transmission to people who have not been vaccinated. So we think that they are likely to prevent asymptomatic infection. That means that asymptomatic infection means that the virus is growing in your nose and you don't get sick. So hopefully the vaccines are preventing that, but they're not 100% against it the way they are. They're not as effective against that likely as they are against getting sick from the virus. There's still subpopulations such as people who are immunosuppressed or on some certain kinds of medications that we don't know how effective the vaccines are going to be in. And so we need to study those populations. But in the meantime, it's important to wear a mask and protect others, because that's the way that we're going to get out of this pandemic, by vaccinating as many people as possible, but in the meantime, continuing to wear our masks. I will stop there. There's my email in case anybody has questions directly for me, but also the phone number and email and website for our center in case you are curious about our work. Okay. So Frida, should I stop sharing now?
Yes, that's fine. Thank you so much, Dr. Talat. This was a very comprehensive, although condensed discussion. You covered a lot of information and answered a lot of questions that we had. But I do just want to reiterate that is there reinfection? What is the reinfection rate after vaccination? Because we have been hearing some stories in the news where individuals have been fully vaccinated and then consequently died from COVID infection.
I hadn't heard that. Somebody who has been fully vaccinated. So that certainly I've heard of people who got sick right after they got their first dose, but I hadn't heard of anybody who was fully vaccinated and died of COVID. But the reinfection rate is about 5%. So if you were exposed to COVID, about 5% of the time, you're likely to get infected even with the vaccine, right? The vaccine's 95% effective, not 100% effective against any illness. But in the trials, the vaccines were very, very good against severe disease. So they're even better than that against severe disease. So even though it's possible to get COVID if you are vaccinated, and we actually, we've seen that in the trials as well, people who are fully vaccinated who end up with COVID, it's much less likely than somebody who's not vaccinated.
So perhaps the message to the community is that after their first dose of vaccination, even their second dose, that they should continue with the CDC guidelines to protect themselves and others, simply because it's not 100%. Yeah.
Yeah. Especially.
Yeah. I have another question. Pardon, Bishop?
Rita, let me jump in just a moment and remind our radio audience that if they would like to see these charts and graphs that the doctor showed us today, they can go on to our Facebook page, Ralph Dennis Facebook page, or to Kingdom Worship Center YouTube, and all the charts and all the graphs that she showed us today, which is a plethora of information, great information. Tell them to please, just want them to please follow us on the YouTube, KFCM, Kingdom Fellowship Covenant Ministers YouTube, or my Facebook page, just Ralph Dennis. Thanks, Freya.
Oh, no worries. Thank you so much, Bishop. We do have a panelist here. They're experts in their own right and fields that perhaps may have some questions. I'd also like to welcome my co-moderator, Bishop Greg Dennis of Kingdom Worship Center, who's joined us this morning. I'm happy to serve beside him today. So for our panelists, which consist of our Bishop Carter, along with Dr. Beelan, Priscilla Beelan, and Dr. Kevin Daniels of Morgan State University, they may have some questions for you as it relates to your presentation. So right now, I'll yield the floor to Dr. Priscilla Beelan for any questions that you might have. Turn your mic on.
There we go. Thank you, Pastor Freya, and thanks to Dr. Talat for an awesome presentation. You did speak on this a little bit, but if you could elaborate just a little bit more. You spoke about immunocompromised and those with underlying conditions. I want to kind of hone in on something specifically because my background in research deals with prevention with cancer, specifically breast cancer with women of color, and a survivor, 14 years almost myself. With a person, and I've been vaccinated with my first dose and will be getting my second dose, but the percentage or the percent efficacy when we're talking about cancer survivors, and we know how that's going through our country and across the world. Could you speak a little bit about those that want to get it, have a little, timid about it, but also the efficacy being a survivor, not in current treatment, but in survivorship?
So people who are cancer survivors, such as yourself, and congratulations on being 14 years.
Thank you.
Disease-free. They were included in the trials, and there didn't seem to be any decrease in the efficacy. So when I was saying we don't know the efficacy of people who are immunocompromised, I was specifically talking about people who are immunosuppressive medications now, not who've had them in the past. So if you have survived cancer, if you're not on those medications at this point, and your immune system should be back to normal, then you should have a good response. There was a recent study done out of Hopkins in people who have had transplants and so are on lifelong immunosuppression because to prevent their rejection of their transplanted organ, and they seem to have lower antibodies to the vaccines, but they do have some antibodies, and so that's important. Is that if they get vaccinated, hopefully it'll provide them with some protection.
Thank you. I could go on, but I'll yield to my other colleagues, Pastor Free, to see if others have questions.
Thank you so much, Dr. Beelan. Also, I'd like to invite Dr. Kevin Daniels for questions to Dr. Talat regarding the presentation.
Yeah, I just wanted to, because my research focuses on urban populations and particularly locality development across districts. Even though I'm not suggesting that the information wasn't valid, but when you talk to people that may be from urban communities, you said several things that are triggering to people that may have already experienced some level of trauma and or woundedness by systems and or institutions, particularly, and I have about 8 of them that are triggering, that needs almost a bridge between your presentation and interpretation, which is from a community perspective. Again, not that you didn't give valid information, but the information as it is bridged over into our community can be problematic. And you mentioned several triggers that I will not be able to go over right here. But one specifically is, it sounds like, from when I hear it from a street level, it sounds like, because you use words like should and hope, and those are not necessarily, even though I know that the percentages of efficacy is 95 and 80 and all of that, and there's some percentages left, and that's why you use that. But for them, this notion of still being possibly in stage 4 clinical trial, because when you mention millions in stage 4, when you look at Pfizer, Moderna, and Johnson, you still don't, your population numbers don't even add up to those millions. So it would suggest that we are still in clinical trial 4.
So I understand that there is certain communities that have very good reason to have significant mistrust of academic medicine, of research, of what we say, and we have made, as an academic community, as a research community, some really grievous mistakes over the past. And because of that, because of the mistakes that we've made, there have been a lot of rules and laws that and oversight that have been developed over the last 20, 30 years. And Pastor Frida is in charge of many of those and making sure we follow those. And to prevent any kind of mistake like that ever happening again. In terms of the vaccines are no longer in clinical. The clinical trials, the phase 3 clinical trials, are still ongoing. Phase 4 is not really a clinical trial; it's just a monitoring. And we have had over 100 million people in the United States now vaccinated with one of the mRNA vaccines, either Pfizer or Moderna, and we continue to monitor the safety. We're not studying it. It's not a clinical trial, but we are continuing to follow the safety, because as you go from a study that has a few tens of thousands of people, 30,000 people, to vaccinating 100 million people in 3 or 4 months, you might see rare events that pop up, such as the allergies, where you didn't know anything about those allergic reactions in the clinical trials because we didn't vaccinate enough people to get an allergic reaction. For the Pfizer vaccine, the allergic reaction happens in about 1 in 200,000 people who get the vaccine. For the Moderna, it's closer to 1 in 350,000. And so we need to monitor. And we continue to do this for all vaccines, all licensed vaccines, the flu vaccine, the hepatitis vaccines, all of these vaccines. We continue to monitor the safety to see if something unusual pops up. So it's not that this is a trial, it's just we are continuing to watch out for safety. But I think that we have I hope that with continued dialogue about the reservations and the concerns and the triggers that people have, we could have a conversation and try to come to an understanding.
Dr. Talat, thank you so much for that, and Dr. Daniels for your question. But I'm also appreciative for your clarification on phase 4 clinical trials, that in fact, we are not in a phase 4 clinical trial, which suggests that individuals are involuntarily participating in a trial without their consent, further adding to the distrust. But in reality, we are all collectively in monitoring post-vaccination or post-EUA of the vaccine. So that information is really critical, that we transmit that information to our communities by way of education, because often people like to say, I didn't ask to be in a trial, I'm in a trial. And those untruths spread a lot further and faster than the truth. So thank you for bringing that clarification so that we can add that language to our vernacular as we're talking to different groups of people. We will be having a segment on those very questions that you raised, Dr. Daniels. Thank you so much, because I know that's your passion as well as your expertise. So we'll be talking further about those things. I do have one question for you, Dr. Talat, with regard to the AstraZeneca clinical trial. There's been a discussion about the blood clots that are happening, and when do you think it might be sent to the U.S. for EUA, and how should that roll out? Thank you.
So as I mentioned, the vaccine has now been given to 20 million people in Europe and 27 million people in India. And there have been rare reports of blood clots, especially of an unusual kind of blood clot where the platelets have also dropped in Europe that have not been reported from India. The European Medicines Agency, which is the equivalent of our FDA, as well as the WHO, have both reviewed all of the data about those cases. And they both came out over the last 2 days with statements that said that the vaccine is safe, that the benefits of the vaccine outweigh the risks, that there is no evidence of regular blood clots that are increased, that DVTs or PEs are increased above what we do normally expect. And I think it's important to remember and understand that just because you get a vaccine, you don't have, it doesn't prevent bad things not related to the disease from happening. So if if your body was going to have a heart attack on May 15th and you had the vaccine on May 10th and your body had a heart attack on May 15th, it doesn't necessarily mean that the vaccine has caused it. It depends on what your predisposing risk factors are. Now, they did say that there might be incredibly rare cases of blood clots where the blood that are associated with the low platelets, and they are continuing to monitor that. But they again reiterated that they thought that this was an incredibly rare event and that the vaccine benefits outweighed any potential risks. And I think that AstraZeneca will probably come up for apply for their EUA at some point, either this month or early next month. And I think Novavax will also be applying soon as well.
Dr. Talat, Greg Dennis here. As there's two things. One is that as we look at the efficacy of the different vaccines that we have, we talked about how all of them are preventing us from being able to end up in hospital and preventing death. But there is, of course, in the community as well, a hesitancy to be able to receive the Johnson & Johnson vaccine, which has the lower efficacy. And so people are now trying to pick and choose where they actually have a Pfizer or whatever vaccine that has a higher efficacy. And could you speak just a little bit more to why, if the Johnson & Johnson is what's available, why we should take advantage of that? Because when you consider the hesitancy of the community, it makes sense in our minds to then, if you're going to do it, then go with what would be considered to be most effective.
Right. So I understand that. The difference between them, again, it's really hard to compare vaccines across different times and different places where they're tried, but the difference is whether they prevent headaches, sore throats, etc. All of these diseases vaccines are incredibly protective against ending up in the hospital, against ending up dead. And so the best vaccine against COVID is the first one you have access to. Because I know a lot of people who got infected right around the time they got their vaccine. So it was just a few days too late and they developed disease. And so the best vaccine is the first one you can get. And, so it doesn't prevent you from getting a cold. Does that really matter? But it keeps you healthy and keeps you out of the hospital.
I do appreciate that, because I was going to, first of all, your presentation I thought was extremely informative and quite scientific too. I want to thank you for that. But however, I was going to ask you about the 3 vaccines that we are familiar with, because in our community, in the community that I serve, Black and brown persons, we have this mindset to sort of rate the vaccines, to sort of put them on a scale. One is better than the other. But I have been giving the answer that you just gave, whichever one you can get to, that's the one you take for the sake of the help that is needed. Now, if you could just say a little bit more for me about the variances that we're seeing in the United Kingdom and Brazil and South Africa, and it sounds like it's more severe in the United Kingdom. How much do we need to have to pay attention to that in our community? Because there is still, I'm hoping it's going to change, but we're still running into a great deal of persons who have major hesitancy about getting vaccinated. And if that continues to occur, then I just kind of need to know what we can do to maybe herd or protect ourselves from these different strains that we're hearing about.
Right. So I think that for the UK variant especially, we should be particularly worried because it's spreading very quickly through the United States. In the UK, there was a recent paper that showed that the risk of basically doubled when this strain entered the country, which doesn't mean that there's it's still too many people dying, but it went from maybe less than 1% of people who get COVID die to maybe 1.5 or 2% of people who get COVID die, which is still, again, when we talk about 30 million people in the United States, that's a lot of people potentially dying. And so, the ways to prevent it are wearing a mask, social distancing, washing your hands, not being inside into close quarters with people who you don't share a household with, and getting a vaccine. And so if the vaccines work just as well against the UK variant as they do against the strains that have been circulating in the United States. So the way to protect ourselves against this variant is to be vaccinated and to continue to practice the public health guidance that we've gotten over the last year and not to let down our guard. For the South African variant, it has now arrived in the United States and is spreading, but not nearly as quickly and not as widespread. The vaccines are likely to be effective against keeping us hospitalized, but as I said, the amount of antibodies against that virus compared to the amount of antibodies that we mount against the US or the UK viruses is lower. And so it may not prevent us from getting a cold, the vaccines against the South African variant, but hopefully will keep us from getting hospitalized or dying. And because of that, the manufacturers are actually now making a vaccine against some of these variants to do a booster, to boost the immune response so that we have more protection. Because if we can still get infected, it's possible that more variants can develop. So we want to be able to stop the infection, so we stop the production of variants. You're muted, Bishop.
In my mind, what I'm thinking, and I may be off base, but the UK versus South Africa, Brazil, where it's the variance is lower, but in the UK it's higher. Would race have anything to do with that? Because I'm thinking black and brown, and UK might be non-black and brown. Okay, just one.
I think it has more to do with when it was the first one to arise. It was the first one to be introduced in the United States, and because it's more infectious, it spread faster. Mm-hmm. So I don't know that race. It just happened to be where it was.
Okay, good.
Yeah.
Thank you.
Mm-hmm. And it may have to do with more traffic and more planes going back and forth between the UK and the US compared to South Africa or Brazil, but I don't think it's
not race. Okay.
Yeah.
Dr. Talat, let me introduce you to that was Dr. Carter, Dr. James Carter. He is the president of the Interfaith Ministerial Alliance of Baltimore, covering lots of churches in our area. He's also the pastor of Ark Church in Baltimore City, just so you know who you're talking to. All right.
Thank you very much. Yes, it's a pleasure to meet you, Dr. Carter.
Dr. Talat, thank you so much for this wonderful presentation. It was definitely informative. You answered a lot of the questions that we had pre-selected for you. And we just appreciate you taking the time to be with us today. We still have more to discuss on this platform, but we're going to move further into our community discussions with regard to inequities. But thank you. We appreciate you.
Thank you very much. It's my pleasure.
Thank you. At this time, I'm going to yield the time to Bishop Greg, and he's going to help us walk through the discussion about communities and Black and Brown individuals and inequities and historical distrust.
Thank you. I'm gonna call you Dr. Frida. I know it's coming very soon. I'm so glad to be a part of this conversation. And today we have someone who's been doing some great study with our Brown and Black communities to make sure that they are represented and being heard. And I present to us today, she is the founder and establishmentarian of Ministry Beyond Myself, Christy Herring, and she's going to start giving us a presentation as it relates to what's happening in some of our other communities that seem to be marginalized during this time. Christy?
Good afternoon. Thank you, sir, for that introduction. Just want to talk a little bit about our Brown communities, in particular, our Latino community, migrants and refugees in particular. If you have been following the news, you're aware of the fact that the COVID infection has greatly impacted that community when you consider the amount of people, the amount of Latinos that are in a particular area. So for instance, if you look at Prince George's County, since we're in Maryland, you look at Prince George's County, Montgomery County, there are about 19% of the Latino populations in both of those counties have been infected with the virus. And high numbers of them have died as a result of the virus as well. And so, and then you can take it on a broader scale and look at it nationwide, and you have about 30% of the population, again, is being affected. So you would think immediately, okay, we have high numbers of infection. You would think that they would be in line to get the vaccine, but that's not what's happening. So the question becomes, why aren't they getting vaccinated? So, you know, initially our immediate response is, oh, we need to provide the information in Spanish, or we need to provide the information in the native language to make sure that they're getting vaccinated. But I think in order for us to really be effective in that community is that we need to step back and look at some of those issues that are relative to them that are very similar to the issues that we have in the African American community, which is that of mistrust. So we have created this culture where our migrants, our refugees, particularly Latin American, people who are coming from Latin American countries, we've created this culture for them of suspicion, of mistrust. We have categorized them as illegal and all of those things. And we fail to realize that those things have now created this environment for them where they feel like they need to hide in the shadows. So they don't feel like I can go and get the vaccine, because if I go and get the vaccine, you're going to take all of my information, put it in a database, and then you're going to show up at my house or at my job and I'm going to be arrested. You know, and so it's more than just providing this information about the, you know, the results, what can happen if I get COVID. We also need to begin to deal with this other issue, these political issues that are behind the fear of getting it. When you have Latin American families, many of them are multi-generational. So if one person in the family gets it, you end up with numerous people in the family getting it, which is why you see the number so high. So we're not really going to be able to address this issue just simply by putting information in Spanish or putting it in French or whatever. But we have to begin as well to change the way that we think about those who are coming into our borders and how we welcome them. If we look at scripture clearly tells us to welcome the stranger. So it becomes our responsibility to create that safe haven for them so that they are not afraid to get the assistance that they need when it is available. And I'll stop there. Thank you.
Sister Chrissy, that is actually really telling, and I'd like to hear, because I think one of the challenges, even Dr. Talat, that is mentioned bridging between what Christy presented and as well as what you talked about, is that stage 4 monitoring. And so if we're going to do something with our Black and Brown communities, there's some way in knowing that I am being monitored. How is that monitoring happening? How does it work? What is being retained? How is it being used? Who is it shared with? All of those components become part of the conversation in question in order to give someone else an increased level of comfort when participating in the vaccination.
So a lot of it is voluntary, the monitoring. There is VSafe that you have to sign up for and report, but that's anonymous. Unless you are pregnant. And if you are pregnant and you sign up for VSafe, they will contact you and say, would you like to be part of our registry so we can make sure and follow you and make sure there's no adverse events, because we didn't include pregnant women in our studies, even though now tens of thousands of pregnant women have gotten the vaccine. The VAERS system is completely voluntary. That's a vaccine adverse event reporting system. If you have a rash or allergic reaction to the vaccine, that is all completely voluntary. There are some things that doctors must report, but that's all kept very confidential. And so we don't gather information on it, that personal information isn't collected. The other systems are all anonymous. So things like the VSD, which is big health agencies share anonymized claims data that says, we had 2 million people in our population who got vaccinated, and this many people had a heart attack. And if you look at, the people who are vaccinated versus people who are not vaccinated to see if there's any increased risk of heart attack in the vaccinated group, you find that there isn't. But that's all anonymous data. That's not data that's collecting any personal information about you. And so any personal information is generally shared voluntarily by the person who shares it. It's not something that's collected or tracked by the government or anybody else giving you the vaccine.
Good, thank you. Thank you. Any one of our other panelists have some questions or things that you would like to present on as it pertains to that particular subject matter?
I was hoping that Dr. Daniels could parallel his perspective to Christie's, particularly since Christie's looking at more the Brown communities and what some of their challenges are. And while we both communities have challenges, they are different in many ways and historical. So Dr. Daniels, can you shed some light on what your perspectives are with the Black community?
Yeah, again, I think that, for the most part, and I talked about, I sit on the subcommittee of the Maryland State Social Determinants of Health. And a lot of what we found even pre-COVID was the fact that most institutions systemically wasn't even taking real responsibility even pre-COVID. And what COVID did was really exposed a whole lot of the disparities going on in our culture. And again, I want you to make sure I'm very clear. This is not against you personally, but as representing institutions that you're talking about well over, again, without going all the way back, you're still talking about systems that are going on, even when you look at the National Medical Association, the current czar of the President Biden and Harris's task force for COVID, all of them have stated that what we're looking at this particular time has been, even Joe Biden said in his speech, of course, that this has been a stinging, these inequities in our communities have been stinging. And somehow or another, I wish that moments like these could be consistent. Even post-COVID, because our community, you talked about with over the last year, but our community has been in trouble beyond just last year. And I wish that we take these kind of emergency measures the same way that we on a more consistent basis, because a lot of our communities, when you say 10% African American are in clinical trials, which is of course a lot more, that is very discouraging and very detrimental and very serious, that I think that it's going to require a collective to really come in and address some of these social determinants of health, but also build trust. Trust deals with accountability. It deals with competence. It deals with a whole lot of commitment. It deals with consistency. And what we've seen from institutions and systems have not been consistency in our communities. So again, let me throw this olive branch. I think this is where we can really work together to really begin to build that trust.
Pastor Frida, can I add something to that? Is it
Yes,
okay?
please. Yes, please feel free.
Okay. I think it's so important. One of the things, I'm trained also as a community-based participatory researcher, did it at Bloomberg School of Public Health, in fact. I wanted to add this caveat, even when I was listening to Christy and definitely with Dr. Daniels, talking about the mistrust and how things have been labeled. I think settings like this is so absolutely necessary in bridging the faith and the science. It must be done. There's a graphic that I actually have that I present at different times showing the coming together, because when you're doing it community-based, we're not at a place where we just need community play stuff now. We've had it as a faith community, and those that are listening now, many of our audience participants perhaps are from the faith community, so that in and out that does not work now are just dropping in. We need to have more platforms, as Archbishop has provided on today, of collaborative efforts where there is equity, because then you begin to talk about it, and we heard it both from Dr. Daniels and Christy about inequities, but where there is that evenly distribution, and you have power players, you have the gatekeepers, you have the stakeholders at the table. And this is what Pastor Frida has allowed in creating this with Archbishop. So I just wanted to add that even as the faith community, as leaders that are in faith community, in science, we've got to create more environments like this where there is real discussion, where culturally relevant and culturally sensitive information is being distributed that speaks to the audience, so that you have those from your target audience that you're trying to reach a part of the conceptual framework that is being presented. I'm going to stop now because this is a very passionate subject for me, but we've got to get it to a place where we are at the table together, developing, implementing, presenting, evaluating. I could go on resources, money, because then you begin to talk about the resources, the grant dollars, so many different things that are needed in the faith community that can help. So I'll stop.
Dr. Billy, let me jump right in. That's a good point. Let me jump right in and thank the Radio 1 and Praise 106.1 audience for being with us today. They're about to sign off, but we are still appreciative of all of those who joined us from Radio 1 and Praise 106.1. And we pray that you can continue to follow us on Facebook, Ralph Dennis's Facebook page, and on YouTube, Kingdom Fellowship Covenant Ministries, 101.6 Radio 1. Thank you so much for joining us today. God bless. Thank you, Dr. Beeling. You may continue your thought if you desire, or our moderator will jump in.
I would just like to add, along with what's being said, is that, so often we are confronted with these one-time events. And when I'm speaking about this pandemic, okay, it's affecting everyone, so attention is put there. But historically, as has already been stated, historically, we have not been in the equation, persons of color, persons Black and brown, and it affects me also, in a personal way, because I'm a Baltimorean. I was born here in Baltimore, but I could not be born at Johns Hopkins. I could not be born at the University of Maryland. I was born at Providence Hospital, which is a hospital that no longer exists. It was a hospital that our mothers and fathers and Black physicians put together. And when the government dollars came down the pipe, it went straight to Hopkins. And again, I got to say too, this is not personally at you, Dr. Talat, but certainly the resources were not there. And if we're going to change the equation, if we're going to change the paradigm, our institutions have to be supported as well, equally. And that's that's really where we begin to build the trust. You show me the dollars, I can trust you at that point.
Thank you all so much. We appreciate all of your questions and your commentary. I also would like to say that Dr. Talat, along with other colleagues and departments at Johns Hopkins in particular, are working very hard to help to bridge some of those gaps in community. There are ongoing conversations about inequities, but not only conversations, taking the time to have some educational platforms, and those platforms are being extended to our faith-based communities. So we are happy to connect with any of you to make certain that you can be part of the conversation, equip you with the necessary tools to have educated conversations with your communities, with your congregations, to ensure that they have what they need to better understand not only COVID, coronavirus, and vaccines, but healthcare in general, because we've been disproportionately affected by the virus, because we've been disproportionately involved in our own healthcare or having access to good quality healthcare and education. So again, thank you, Dr. Talat, for being with us today and sharing this important information. And to all of our panelists, we just applaud you and appreciate you for your time and for your insight as it relates to our community and how we need to grow as Black and Brown communities and as a faith-based institution. At this time, Archbishop Ralph Dennis, will you have our closing remarks and questions?
Great, thank you, Pastor Frida. Thank you, Dr. Talat, for a tremendous presentation and for staying on with us. We've certainly appreciated it so very much. I'm going to share, we've got about 6.5 minutes left. I'm going to share that with any of our presenters who feel like there's a point that you would like to make to our listening audience, our viewing audience, about why perhaps we want to encourage them to take the vaccine, get the vaccine, or any other information you might think that would help them. I know one of the things we've been tested with is how available is the vaccine in certain communities where transportation is a problem, communities where registration for the vaccine is a difficult thing to do because you got to register by computers and those kinds of things. Any of our panelists would like to jump in, just comment on that. That would enrich our audience for these last 6 minutes. Jump in, and in the last minute, I'll close us out.
I'd just like to say that I've been in conversations with the Lieutenant Governor, and in the next week and even next 2 weeks, a lot of sites are going to be opening up, particularly at our churches. The whole idea is for persons to have the convenience to be able to walk to a site rather than stand in a long line, et cetera. And I'm hoping that we will take advantage of that, because while we want you safe, it's more about your family as well, those who you're in contact with. Dr. Talat gave us a great illustration in terms of how that herd immunity works, and that's very factual. So I'm hoping that we will just put aside the hesitations that we have. And I'm going to leave you with this. One person who I know took the vaccine, and he was in a facility where there was both white and Black. He made it clear they didn't go to one box for him or went to another box for the white person. They all came out of the same box. And so it's important that we understand that what happened yesterday cannot prevent us from being protected today.
Awesome, awesome, awesome. Dr. Daniels or Dr. Beelan, Dr. Herring.
I'd just like to, just add to tag along with what Bishop Carter just stated about encouraging our communities of color not to allow fear to inhibit you from accessing and being a part of something that can really impact your life for the good. One of the things that Dr. Talat stated, and I hope it really stays in our minds, because of the fast track, it did not minimize the rigor that is done with the clinical trials. And I would share that with others at times. It's because of the money that was really put behind it, but all of the clinical protocols were done in each of these phases. So please, as we come together and encourage our loved ones encourage those in our realms of influence not to allow fear. We know that there is ample reason for mistrust, but we've addressed those things and we will continue to have that dialogue regarding that. But we've got to work together and begin to move beyond that so we can ensure our families and our communities are healthy. Thank you, Archbishop.
Right.
And again, I think that continuing to build trust as we're doing, it's going to be incremental. It's not going to be something that is instantaneous, continuing to do that, but most importantly, to understand the stages of that level of trust. And that begins with accountability. And please be clear, some of our institutions have not been accountable. So we couldn't even go on to some of the other stages as it relates to consistency and those levels of commitment. So, but those of us that are here, this opportunity, we're saying, I'm working with, we calling her Dr. Frida, I'm working with her to, as a part of Johns Hopkins, so to keep that moving, but still being very clear. It did not help that we had a Trump administration that continued some of the things that it did. But then lastly, to be very clear, when you say warp speed, when you say monies have been poured in, you start to raise the question of why wasn't monies poured in before?
And why didn't we receive it?
That is right.
Yeah, those are definitely concerns that we cannot ignore, particularly in our communities. But I am hopeful that platforms such as this will continue, and even in our individual spaces, we'll continue to have conversations that educate. Information is power, so that it helps to weed out some of the misnomers, some of the conspiracy theories that just keep our communities in bondage. And by the time they realize that it is true, often the resources depleted. So we're hoping that we can take these conversations, even the information we've garnered today, and share that in our spaces and places of influence. And just FYI, I've been vaccinated and I'm still here. So that cancels out that conspiracy theory. And I'm looking forward to continued improvement in our communities. Bishop Dennis?
If I could say something, Bishop, right before you close, I do want to, I know I've been kind of throwing punches at Hopkins, but I do want to thank Hopkins for what has been done. I have a relationship with Dr. Lois Previtt Dunn, and I know she's a part of your organization. And I do appreciate the reach out to our community at this point, and we're hoping that it will continue to go forth. Yeah. Thank you, Bishop.
Okay. All right, we're good. If any of you have missed any part of this webinar today, you can hear it again on the podcast for Praise 106.1's website. You can go on the website for Praise 101.6 and you can hear this webcast again on their podcast. So please check in with it, play it again, share it with others, let others know that there is some information out there. I want to thank Dr. J.L. Carter, Dr. Kevin Daniels, Dr. Priscilla Beelan, Dr. Christy Herring, and our moderators who have done a tremendous job today. Dr. Frida Anderson, wonderful job. Thank you so very much. Along with my own son, Bishop Greg Dennis, thank you. And Dr. Talat, you are a winner in our corner. We appreciate you. God bless all of you. Have a great day. Enjoy your weekend. And Lord being willing, we're going to do this again sometime in the future. God bless. Thanks for listening. Thanks for joining us. I think we're off.
Yes,